um, chest, sit out chest. So like, yeah. Um,
missed an opportunity to bring the baby back to the hospital. How it was a disease which could last for the The second baby which I can remember who didn't do well was a baby who was born to a family with two previous losses. One of them was a microcephalic child who died for 5 years with severe developmental disability. And this baby would continue to have very bad cyanosis with very little experience. And we managed to discharge the baby on all sorts of pulmonary vasculitis after the 3 months. Baby is now 2 years old, but 6 months of now the baby kept coming back to the hospital with cyanotic so it's very difficult to manage and we have a kind of an ED team who pediatrics, but please don't try to intubate him to make it worse. Just give a lot of vaccines and everything. So he was a different kind of baby who was on respiratory support for very long time. I'm just trying to share what real spectrum we have. And there is a baby who we had 25 week old, the previous baby being 28 week old, went home, baby is now 2 years old, and home oxygen and mobilizations, and every once in 2 to 3 months he gets back to PNC and water, gets ventilated for 2 3 days and goes back. Whatever genetic tests we have not known what we've got. Very bright looking fellow, very active, what those various and gets back to come. There were other babies who didn't have such a terrible course, but went home, came back on third day with RSV pneumonia, got ventilated for 1 or 2 months. And with that, we started doing what's called cocoon vaccinations, and we didn't have the palliative. And we just started using palliative. I don't know whether we changed everything because as per literature, only 50% of what was RSV. And we are also seeing something 50% varina, which we will not be able to still change. One baby had what we think should have been a healthcare associated infection. One case was very long one. Till the baby went well, and bad lung vertigo. And that is why the baby was when some area of peace. So the baby told us now, it was possible was to do for us. Many of the things again are struggling in the ICU and probably ultimately cardiologists would say sometimes it's severe pH, sometimes they would say it is very bacteria which may go to the problem. One day finally I was open in this story and from the next day onward to never had any respiratory disease. So there were 4 months of hope in this story. So this is what I have a briefly like presentation. We have done many tracheostomies for neurological disorders and airway disorders, but only one for BPD. It was an outbound baby referred to us. I sorry, don't have a follow-up on what happened to the baby, but the baby didn't go home on home ventilation. He went only on a tracheostomy and home. There is no end to number of babies who are doing well after going home on home oxygen. Some of them are possibly mild to moderate BPD and they just got better in 3 4 months, just got some oxygen at home. And many babies, we all are the hospital for 3 to 4 months with very different patterns of why they require respiratory support. They're doing well, and surely they will not be discussed today. They are all these mild BPDs who do better not because of us, but because they are not sick. So this is the first message among two messages I would like to share today. One is that whether we like it or not, are there any members in the hall today who are training for neonatology? You don't have to set up, just yeah. I feel a little that you have a difficult journey ahead because what I, Nisha, Maya, and Lakshmi ventilated was child's play for you today. Yes. Was babies who were less than 24 months old and never discharged from hospital. So the BPD definition was that the 36 weeks on respiratory support, but in 24 months they have not been sent home. We are getting tired at third and fourth month, and I must confess that in both the previous babies, we were more tired than the family and the baby. We were not sure what to do. Average length of stay in this consortium study was 4.5 months. This is only average, but longer numbers were there, as you can see. And a similar study group is there from the US, which is called as the Children's Hospital Neonatal Consortium. They have a data which is not different. So a recent data analysis of what is going to happen, the blue line is babies who are having BPD in extreme preterm babies, less than 28 weeks. And you can see that the number is close to 60%. 60% of babies would be on respiratory support at 36 weeks. And if I break up this slide a little more, don't get confused by those multiple lines that are going in. The dotted line is very close to the 26 weeks. That is the average of all extreme preterm, but it's very easy to remember for postgraduates that 60% for 26 weeks and 25 becomes 70, 24 becomes 80, and 23 becomes 90% BPD. So they would all be in hospital beyond 36 weeks of PMA, which means a 23 weeker means 5 months automatically. And this is the least. You can see that they could be till 2 years, and it would be the 23 and 24 weekers would spend longest time with us. So, which means that just like what we are seeing now, and I'm sure Nishad is seeing, Mangala is seeing, and Lakshmi is seeing, half of the unit is having babies who are once 23 and 24 weekers, now 44 weeks, 43 weeks, on varying levels of respiratory support. Fortunately, only some of them are still ventilated, but that is going to change. So by definition, we are using a terminology called as respiratory support at 36 weeks of post-menstrual age. But even though we were teaching and learning that they are not the same, this talk has helped me to reorganize my thoughts and understand that really, like the story I told you, there was somebody who required coiling, somebody who required ventilation, somebody was cystic fibrosis, somebody was TAPVC. We are not dealing with the same thing actually. They're all different babies. These are some of the MRI images that were there from babies who had this, and you can see in one baby you had atelectasis on one side and cystic changes on the other side. Another baby had cystic changes all over, and there were babies who had only hyperinflation with no lung at all, and probably they just had a lot of volume inside but no surface area for exchange. Just like in our stories,
like the baby who had only VAP, some of them may be infection and that's why they are not going home. Like the baby who had been in utero for one more week and we thought some lung hypoplasia got added on, they have sheer lung arrest and maybe the last kind of image. Many of them we are treating as pulmonary hypertension because that is the only one we have medicines for. Not that really that is the biggest problem. We have a lot of new medicines. We can throw sildenafil, start nitric oxide once a while, but we don't have any lungs to throw into them. We have recognized that some of them had tracheomalacia. I know of one young pulmonologist in Bangalore who is willing to stent the airways. We have talked to them once, but we have not tried it. I don't know if somebody in the hall you can share with us. There is a Japanese team also which maps your airways and uses synthetic material and they'll just shoot it in. We tried doing that for the esophagus, but not for trachea so far. Vocal cord palsy, granulation adhesions are not at all uncommon. And before you really give up, one look at the larynx is worth because simply a laser of the posterior adhesion might change the picture for the baby. Hyperreactive airway is there. We treat them. In all these babies, we have used randomly salbutamol, ipratropium, and various combinations. But I don't think they did magic for us ever. PDA in every way is troublesome when it is there. And this is not the same PDA what you see on the first and second day of life, where you're trying to give brufen and indomethacin and trying to save the brain. Metabolic bone disease does contribute. It does make this one we have found that babies who had MBD later on with very low phosphorus and lot of alkaline phosphatase and flail lungs, these babies in the first and second week continue to have low phosphorus despite of giving IV phosphate. And they were different from babies who later on didn't have bad MBD. When they got IV phosphate in the first week of life, their phosphorus levels went up. They didn't get MBD at all. Same babies who had BD also, which means that within the 26 weeks, there are some babies who can't retain the phosphorus just like the other babies. Nutrition is a challenge. GERD is somewhere between what we do and what probably the Western do. They seem to have a lot of GERD, we seem to have none at all. So there has to be something in between. And genetics does play, and that is why 26 weekers, 60% have BPD and 40 don't. What we don't know which 40% and why 40% don't get BPD. So in this next 15-20 minutes, what I will try and do is try to learn from the mistakes that we did in the last few babies or learning what we did. And this is the kind of interplay you would have. You would have some infection, some CMV, some PDA, some phosphorus, so much chaos. And actually, the management we were doing for these babies was not different. It depended on who took the rounds. Somebody would increase the eye time. Somebody would give albuterol at night. And they had good justification to do different than what was planned because the baby would crash, he would become blue, his CO2 would go to 110, he would become drowsy. And when they gave a puff into the baby, he became better in the morning and they said this is the right thing to do. The next team came and felt differently. So we know that trying to find some order is a necessity, otherwise we would be just chaotic. And when I called my senior Dr. Harijit, who is in US, to see the baby when he was on a holiday, he said, we are not any different from you. There are babies who are 10 months, 11 months old, weaned, looking at the parents are gone back to job, and we do different managements in morning, afternoon, and evening, depending on how the baby behaves. Yeah. Thank you. So what we know currently or what we practice currently is, I don't know whether I lost it for you. Are you? Yeah. Take your time. He's gone to stop share by mistake. So if you have been reading recent papers on BPD, they try to add on airway to the existing knowledge of alveoli being poor and vascularity being poor. And we have started learning that there is surely some airway. But when we manage these babies, we realize that we had started asking what is happening to alveoli, what is happening to vasculature and airway. But there was many more areas to be added on. And it can't be just these three things of a lung, vasculature, and airway. There were many others we discovered as problems that we faced. I feel that BPD will have to be labeled that way soon. So what I marked in orange is the typical three orders of BPD is pulmonary hypertension, bad lung, and airway, which will be in the next slides. But, and only one of them has a name currently, BPD-PH. We don't have a name called BPD-A. You can correct me if it is in literature already, or BPD-L, BPD lung. It is not there. But it will have to be there because if you hear the number of cases that we could not manage perfectly, the problems were different in different babies. They were not the same. Because I'm not going to go to details of what you're already doing, they would just run off in one vertical in each slide. In pulmonary hypertension, for those who are postgraduates in the hall or are on the Zoom, most of us are doing echoes if we are not out of severe respiratory support or oxygen by 4 weeks to screen for pulmonary hypertension. But please understand that this is not having any standard parameter as yet, because it is not the same pulmonary hypertension as you see in a congenital heart disease with an Eisenmenger like physiology. So the problems may be just a few vessels than just high pressures. So you may not be able to see the same, but still it is a norm to do echo at 4 weeks for screening for pulmonary hypertension. And what we land up doing is, even if we don't find pulmonary hypertension, we still land up adding sildenafil if the FiO2 is very high and there is no heart disease, because we are desperate, not because this is current science. People, the scientific community is not sure whether sildenafil is the right thing to do. I was not aware till I was making this presentation that sildenafil is associated with a lot of GE symptoms, and therefore another guy called tadalafil is being tried, which is associated with less GE symptoms. I have no personal experience. Colleagues can add in. We do have a nitric oxide and we add on once this, but it only does magic for a few hours in these kind of babies who are stuck on ventilator after 1 or 2 months. We have used milrinone when they got new infection again. They became very sick, but not. After asking Dr. Jain, who is an expert in pulmonary hypertension in Amrita, but it didn't help us. All we seem to know from literature is the target SpO2s may be higher in these babies than what you keep for other premature babies. One of the arguments is that you are beyond that stage when you may cause ROP. And second is they may have less crashes when if you're keeping higher target saturation targets. VAP is common. In the first few weeks, it may be gram-negative sepsis. We blame ourselves. I don't know whether we are right, that because this baby got gram-negative sepsis in 2 weeks, that is why he is in as bad a shape as he should. Maybe we could have prevented this, but there are others babies who did not get gram-negative sepsis, but they still get BPD. We kept brushing out corns as a contaminant, but it is coming more often than not. Some had fungi. And why I marked CMV in yellow is because we don't know enough, but we surely are finding many babies who we investigate and they are not out of ventilator with counts like 9 lakh copies. We treat them for 2 weeks, their copy counts just disappear. Some of them got better. This was a part of a student research work which was going on and trying to see whether mother's milk has CMV and whether babies get affected. So it may be worthwhile, and some of these babies had negative CMV, and got into 9 lakh copies after giving a DART regime. So there is some association. Some of them, when we did association, there was no association with breast milk copies, but very strong association with transfusion, even though the transfusion was CMV negative transfusion, in the sense that it was a leukocyte depleted transfusion. So while the study was going on, my co-guide didn't want to investigate that. They said, no, it is leukocyte depleted, never can do this. But I think we want to look at the blood, which is leukocyte depleted, whether it does contain some CMV. But these babies had a strong association with transfusion as well. We threw in a few mycoplasma treatments because the pediatric OPD was seeing children with what we call as walking pneumonias. And there was some previous literature of talking about mycoplasma causing this, but it didn't change much. Other than the initial management of PDA that we do with paracetamol and brufen, we tried coiling a few babies. One had a magical response, not all others. And indomethacin, which was used by me and Nishad as first liner, has now been pushed down, and some people still use it as a last resort before considering surgery. And one or two had a PAPVC and TAPVC, which was not seen in the previous echoes. So congenital heart still might not show up. We all see certain babies who are absolutely well, but keep on getting only apneas, get very high doses of caffeine, either get little better, or when I meant by HFNC, this is really stretching that I wonder, and I put it in a lighter vein, that if I sneeze in my unit, my resident would put me on HFNC. So they love HFNC so much, they don't want to take the baby out of HFNC at all. If I take it off 1 hour later, they will have a justification for putting it back again. So babies are on HFNC for a very long time. Some of them get NIV through RAMS cannula. I don't know how it happens, but when you fight with the younger generation, it looks like old versus young rather than NIV versus HFNC. And PRBC transfusions get thrown in if baby gets one apnea last night. So whether it is justified, whether it will help, we don't know. Terrible lung is there once a while. We use less diuretics than literature describes, but we are forced to use when the baby is flooded. Postnatal steroids, I think we have used both. Inhaled, IV, all we have used. Somehow the magic which was happening in the initial days is not happening. I think we were looking at bigger babies earlier. But when it comes to this 23, 24 weeker, steroid is not doing anything to them actually. We do a few CTs, but not very happy about it. When we are reviewing literature for the Cloharty write-up, there seems to be huge discussion on interstitial lung disease in neonates. We have not found any on genetic workup till date. Dr. Harijit told me they have found a few immotile cilia syndromes and things like that. Metabolic bone disease, we do use phosphorus standalone sometimes, but now there is understanding about calcipenia also, so it can't be only phosphorus. And active vitamin D also is pushed in sometimes, but if the baby is flail chest and not a bad lung. Trying to get nutrition in order. We'll talk one slide about mom later on, but vitamin A I'm not using, but literature also seems to have gone out of favor. Trying to push in more protein, we don't have many options. Airway is a real problem, and if you see BPD spell, it is probably both. It could be a caving in bronchus, caving in trachea, which doesn't allow any ventilation to happen. And the other one may be a pulmonary hypertension, which is getting worse. And the difficulty is, in one you need more PEEP, like in tracheobronchomalacia, but in pulmonary hypertension, it will make it worse if you put a lot of PEEP. So trying to split these two is challenging because you do an echo, during crisis, you will invariably find a pulmonary hypertension. Dynamic studies have been discussed, but we were not able to do it easily. When you can't keep the baby saturating in the NICU, imagine taking him to the OT, analgesia, and doing a video laryngoscopy to see whether the tracheobronchus is collapsing. It is like somebody's death at your curiosity of knowledge. Inhaled bronchodilators were used, but not much great help. In reflux, besides doing the routine things, I just wanted to put one word on cow's milk protein allergy. Nalini from Hyderabad has submitted some papers which I got to review. And it was at that time we saw one preterm baby who had 3 anaphylaxis episodes giving HMF. We are nervous. We talk that newborn babies can't get allergy. But the first one was on day of HMF, we thought it was sepsis. The baby became hypotensive, got 100% oxygen. And was capillary leaks everywhere, culture negative, recovered after a few days. We didn't think of HMF and an association at that time. Just had read about Nalini's paper, and after 1 month when somebody added HMF, again the baby had the same event. And the third event happened when he received his combination vaccines in the NICU, and one of the combination vaccines has cow's milk protein in it. And we found that this baby had 3 anaphylaxis events in the NICU, went home. At 1.5 years of age, we introduced first curd and then milk, diluted and milk. And within 1 month, he was back to PICU, ventilated again. So it must have been a cow's milk protein allergy. After that, we started looking at a few babies who got worse after HMF, whether protein allergy could be a component of theirs, what we think is refluxes and worsening. Genetics, we have done a few exomes, but we haven't found what we know is there in literature about surfactant disorders and many other conditions which can present in this way. So this is what tracheobronchomalacia would look like. It is not uncommon. We had talked about literature, but we saw it that a baby who was on 2.5 tube gets into 3, 3.5, 4, and even 4.5 with cuff was looking as loose. We tend to dilate their vocal cords and the bronchus, and we can't seem to ventilate them. And it is not only that part, the whole pressures is making the whole bronchus pliable, the trachea pliable, and they just seem to collapse completely. You take the PEEP off from 10, 12, they crash. But we don't know whether they would repair in 3 months or you would have to do a plasty later on. So what should we do? How do we manage? First is to keep them alive. You will have to go through so many sepsis spells, cyanotic spells, the nutrition, and so on. And in that process, quality of life remains important. They need to grow. By this time, parents start Googling and they have more knowledge than we have, honestly. And neurodevelopment and prevention of infections becomes a challenge. So what are the daily bedside concerns we see in these babies? First one is ventilation. And we learned in these few difficult babies that some of them need PEEPs of 10, 12, the kind of numbers we are afraid to give in newborns. Very high tidal volumes of something like 10, 15, 20 ml per kg. Very long eye times. I have to confess that my colleague Ajay was trying to give eye time of 1, and I thought he was wrong. And probably we learned only along the journey because we didn't manage these babies for 20 plus years, and unlearning was tough. He is a young man, he's trained in ICH with Mangla and fast learner. So he came back and said, no, sir, they need eye times of 1 second. And lower rates of 10 to 12 to allow longer E times, which is described as 5 times the eye time. So this is like pediatric ventilation, not like newborn ventilation now. HFO, most papers have said it don't work, and we also found babies not improving when we give HFO because it probably cuts down on the I time and E time very short. Home oxygen, home ventilation, and tracheostomy, I will just touch upon when I go across. We did sedate a few babies with midazolam. I could not find even a single paper in literature talking about how to sedate BPD babies safely. There's a lot of papers on BPD, a lot of papers on sedation and what not to do. But I hope I have not taken it away from you. And but none were there on in these situations. We've been talked of about ipratropium being better. People have used it, and about dexmedetomidine, I can't even pronounce it, and we have not used it. We had challenges in babies having large hernias sitting in the same BPD baby, both sides, and every alternate day threatening to get into an emergency. Now, how to do a surgery on such a baby who is having very bad BPD and a very large hernia or some other surgical? So elective surgeries became a big challenge. One baby we did after waiting for 3 months and became better, and we had to redo the whole thing for 1 month. He was into bad ventilation again. Bronchodilators. I had laughed at my friend who is a pediatrician and was using Montelukast in newborns, and he was giving an excuse that he heard in a respiratory conference that it is steroid sparing. But I found Montelukast has been used in prevention and management of BPD in RCTs and have with some benefit. Vaccination, when we didn't have RSV, we tried doing what is called cocoon vaccination. That is, once we knew the baby will survive 1 or 2 weeks after staying in the hospital, we used to tell all the family members to go and take influenza vaccine, DPT vaccine because ours is a very strong parent participation unit, and parents walk in and out of the 24 hours they can walk to the baby. So they were one of the other people who would bring in RSV. With me bringing in, it was okay because I was a doctor. I used to go to OPD in the afternoon and come back in the ICU in the morning. But doctor's RSV is not dangerous, you know. So we didn't consider ourselves a source of infection. Costs were not just money. The bill of the last baby was 35 lakhs, and because he was our student, we got 9 lakhs concession from the institution. One was 40 lakhs. They were covered by insurance till 25 lakhs, but emotional fatigue was maximum with the doctors and nurses. We are not used to ventilating babies for 6 months as yet. Most of the parents were stronger than we were. And parent participation is required. Single family room is a dream with these kind of babies. And lung transplant or lung heart transplant is something which will be later on. Now, why ventilate with different strategies? I can't give a detailed explanation in 20 minutes, but it appears that the compliance and resistance of different parts of lung may be different. And if you want to keep all of them ventilated, you need a long I time. It can go as long as 1 second. You need high tidal volumes, which can be as much as 10 to 15 ml per kg. So this was one of the review articles from how they ventilated babies, not recommending how they should ventilate babies. So you can see the tidal volumes. This dotted line is nearing 9 mLs. There were many people who are using tidal volumes of 12, 15. The PIP is sitting at 31 here, and there were many babies who got 50 PIP, many units, not babies, centers. Many gave 40 PIP, 60 PIP, that kind. The PEEPs were often at 10 and above, and rates were still high as per the recommendation. They were 20 to 30, and I times were going up to 1 second, 0.8 seconds. These are center descriptions, not individual baby descriptions. So this is from the BPD consortium. They have suggested from a study from Turkey based on pathophysiology that this may be some recommended guideline on managing established severe BPD that use higher tidal volumes, 10 to 15 ml per kg, longer TI, higher PEEPs in those who have epileptic lungs, slower rates, and they just propose one mode of ventilation, keep saturations higher, allow some carbon dioxide, keep the baby calm, try without sedatives because finally brain is important, and wean with patience and cautions. This is thing we didn't learn. Every one of us wanted 1 week after that the baby would be extubated, and we are 6 consultants. The minute 2 agreed, we extubated the baby, and next day the baby was back on higher settings. So it took us 3-4 months to understand that you can't extubate them when you wish, like in other babies. This was an interesting, although common sense guideline on how to manage VAP. Making a diagnosis of VAP in newborn is impossible literally because you can't do what is called bronchoalveolar lavages, and you may not get culture positive each time from the blood. So if you have a baby worsening clinically, some X-ray finding and some systemic signs, you have no choices but to treat with antibiotics. And if they have a negative culture on the ET, they improve clinically, stop in 48 hours. If they have any one, you may continue longer, and if they're not improving, you may be forced to treat for longer time. So this is just a pragmatic guideline on how to treat VAP in these babies. With diuretics, I could find only 2 guidelines. One was that start a diuretic only when you have clinical fluid overload. And second one is try it for at least 1 or 2 weeks before you decide to continue it for longer. In our unit, we tend to stop diuretics faster, but most of the American literature tends to say continue diuretic and allow the baby to auto wean. That is, when his weight increases, the diuretic dose will decrease. So some of you possibly are using more diuretic and may be able to help, but we try to stop diuretics in 2 to 3 weeks. Bronchodilators. Again, the literature review showed that half of these babies received bronchodilators, and the practices were variable between units. The use of bronchodilator is variable. We discovered that nebulizing the bronchodilator into the ventilator was more difficult and less effective, but using that meter dose inhaler connected to the ventilator seemingly is better to give effective therapy, but it didn't change much for most of our babies. I kept the slide on steroids blank because it has been over discussed, and I'm sure anybody in the hall would have used DART regime, and everyone would have used inhaled bronchodilators praying that it will not cause harm. But when we are talking about neurodevelopment and issues, I'm not sure how much of it is only steroids effect directly, or are there some of this CMV like fungal infection, something else which gets re-triggered when we give steroids, and whether they are responsible for what went wrong. In pulmonary hypertension, the threshold for looking for pulmonary hypertension can't be based only on high FiO2s and cyanotic spells. The presence of bad lung disease, apparently more reflux, airway problems can itself add to pulmonary hypertension. And if baby is having even disturbance during care, that itself is a threshold for wanting to investigate and treat pulmonary hypertension. In airway, the problems may be bronchotracheomalacia, hyperreactive airway in some, vocal cord palsy in some, and in one I cannot forget, the baby would crash after extubation, and laryngomalacia was what thought was there. Maybe saw there were adhesions in the anterior commissure. They just did a laser treatment of that, and the baby was out next day. So they can have some adhesions and granulations of the vocal cord, which need to be cleared. Now, how do we measure scientifically that we are doing well with our treatments? It can't be just response of survival and death, because we saw that BPD is different in different babies. So you have to measure lung as an outcome. CT is both difficult to interpret, less clear than MRI, and its radiation. So there seem to be some scores, MRI scores. I'm not trying to, can't remember in Japanese name is there for an MRI score for lung. That seems to be one of the most agreed upon biomarker. So if you're trying to do a RCT on trying to see whether giving a stem cell or not giving a stem cell would work, then you would be doing lung biomarkers with MRI to see whether it helped you or not. Prolonged exposure to PDA, one paper was there which said that if you had a PDA open and severe for more than 60 days, they had, this is the name of the MRI score, OCI MRI score. They had a higher OCI MRI score, and therefore exposing the babies to adductors for a long time may not be a good idea. But all these are retrospective studies, and therefore you can't make direct interpretations. This is another area which we may not pay attention to. When you have ventilated a baby for 4 months and some of them for 24 months in the more busy units, you can't send them home and say, now your child has cerebral palsy or he is having a attention deficit disorder. Harijit, who is my senior at 11 months, said that they have therapists coming and starting doing speech therapy for these babies and talking to them in the unit so that they have normal development later on. So a group which was trying to look at, are we habilitating these babies well, made some conclusion like this, that they did not have sufficient nurses in the unit for participating in habilitation program. Parents were not guided sufficiently to do that. There was no conducive, effective environment to do a habilitation program. I'm talking of babies who are on severe BPD, ventilated at 3 months, 4 months, and lack of a consensus guideline between clinicians and therapists on what to do. And all these need to improve, because we are trying to look at babies who will have better outcomes and not just surviving with BPD. Coming to home oxygen therapy, some of you may be doing it more than we do. We might have sent maximum of 10 to 12 babies with genuine home oxygen for last 10 years. But even a small country like Thailand is discussing something like 40 babies or odd who went on home oxygen, and their mean age of withdrawing oxygen was 13.8 months. This is one of a very smaller country and underdeveloped world description. Tracheostomy, we did one tracheostomy for BPD, but I have no follow-up on that baby. And you would eventually do a gastrostomy also in these babies to feed. And median age of considering tracheostomy should be before 120 days and 44 weeks as per some, to get a better outcome. But some have put that as a threshold for deciding on tracheostomy. So the baby I discussed, one of them was my ENT resident, and she had seen some of our tracheostomy babies for other reasons during her residency program. And from day something like 60, she's saying, please don't plan tracheostomy for my baby. I'm scared when I see baby with tracheostomy. So we didn't do it for that baby. But there are several guidelines based on severity of lung disease when to do tracheostomy. So what we feel currently with managing these babies, the minute you get a 23, 24 weeker, there are some babies 400 and 465 grams in the unit. The residents are thrilled. They think that they have going to see one of a smaller and smallest baby. My nightmares of managing these Joes and say who we didn't save and those babies who struggled makes me feel burdened every day. I can see talking to these families for longer hours. This is what we feel. But very honestly, this is nothing at all. We are going to see something worse. And this is one slide I want younger people to focus on. While I was reading, I found this paper on tracheostomy and home ventilation. And look at the kind of numbers they are talking. In 2013, 100 babies were sent home in this paper with tracheostomy and home ventilation. And the age at which they stopped doing ventilation was 24 months. Age at which they decannulated was 4 or 5 years. But they're talking about 80% survival. Another paper in 2020, 200 babies on home ventilation. Median age of taking out a ventilator is 2 years. Median age of decannulating is 4 years. And survival is 80%. So which means this is what our future is going to be. We are not our babies are not less smart, nor are our doctors. 49 babies, 180 babies, and 98 babies with similar home ventilation for 2 years. I don't know how many of you are already doing something like this in the hall. And decannulation at 4 to 5 years. 1 or 2 slides on genetics and something that is going to happen. Should be all of these babies not as bad because we gave them gram-negative sepsis or CMV or blood transfusion, or we didn't manage the fluids improperly. I am not having much knowledge of genetics, so I'll just put one summary slide which came in a meta-analysis recently, saying that these are some genes they have identified as having association with BPD, and maybe they'll be part of panels when you start seeing a baby who is on respiratory support at 1 month. And some drugs have been been discovered, some of them in the pathway of trying to grow the lung, and some of them in preventing inflammation. So this one slide is important to close up in next 2-3 slides. What I want to say, that preterm lung is something that this is what I use this picture to talk to my parents, saying that this is where your lungs are. This is what they were meant to be. They would have grown to this if you had not given this baby to us outside. But outside now, you don't have the growth factors, you don't have the right proteins, you don't have amniotic fluid in your lung, and you have us ventilating the baby with oxygen pressure and infections, not allowing the lung to grow every day. So it would take several more months than what nature would have done to get somewhere there. This is something you've already seen, and it's very handy when we speak to parents as to why we are having such a struggle with ventilation. When you're talking of a 23, 24 weeker, leave alone alveoli, you don't even have sacules, you're ventilating the airways. And I can't seem to understand how adding surfactant steroid on the first day or second day would allow lungs to grow normally or prevent inhibitory damage, which is going to happen subsequently. Personally, I'm not a proponent of trying to look at these therapies. They can't do magic to grow the lungs for you. So why are the lungs not growing? It is well known that there is a reduction in the resident stem cells in the lung. There are no stem cells. They need to grow, and these stem cells we took away. We took away the growth factors which are there in the amniotic fluid. We took away the microbiota which are needed for the baby. We took away the estrogen. There is a very interesting study showing that amniotic fluid estrogen levels is 100 times that is there postnatally. And they did one human study where they tried randomizing babies to some estrogen therapy and not, and the BPD severity was less. So this is just one molecule we discovered besides growth factors and things which are going to have some effect. Now, why this mom again is that we know mom has stem cells and it has had some role in prevention surely. So based on how much exposure was there to mLs of milk, there was decrease in BPD. You saw that so many factors play. It is not just the stem cells, but they do have a role. Whether it will have a role in repairing is something we will have to see, but in prevention it is well proven. So coming back to ending where we started. If you think I presented so much of disjointed data, hurried slides, but I wish I had the whole day to tell you, 4 months to tell you how we struggled with these babies. It was harrowing, and seeing them dying, and then it's a small town, Trivandrum, unlike Chennai. Every week I land up in these parents somewhere in the mall, and I had to just give them a hug and say, I'm sorry we couldn't save your baby. After 4 months, 5 months of staying in the ICU. So even though literature has given them uh, only 3 current groups saying airway, angiogenesis, and lung, I think there will be something like this soon. And when you take rounds, you may have to tick which box are you managing that day. It will not be the same next day also. Today, is it BPD lung with very bad atelectatic X-ray, high CO2? Then you may be thinking of PEEP, you may be thinking of other things. Is it pulmonary hypertension today with very high FiO2 and echo showing? Then today you may give nitric, but tomorrow it may not be required. It may be hyperreactive airway. You give some inhaler to the baby through the ventilator, tracheobronchiomalacia, and you may have contact this young gentleman in Aster in Bangalore. If I want to stent your lungs, if somebody is already doing it, I don't know. Some of them are just normal, but they keep on throwing apneas. They look neurologically normal when not, and some have PVL. So they're all BPD CNS maybe, BPD apnea prematurity, and vocal cord BPD. Please don't forget that it is quite curable with having addition, granulation, and that's why you can't extubate them. Some may be better by PDA coiling. One at least was very bad VAP. We tried blaming everything else. MBD may be there if your lung is well and the baby is caving in, everything is going wrong. Nutrition is currently a mess. We are not able to keep mothers sustaining to give to these babies, and other proteins which Western literature have, we don't have access to them currently. GER with some cow's milk protein allergy may be there. Hidden congenital heart diseases are unsurfaced later on, and genetics is something which is going to be required. Otherwise, we will not learn better as to which are surfactant deficiencies, and that's why they are not getting better, and we are throwing therapies at them. Thank you for staying on, and I hope you will be able to give us more answers.
Thank you, sir, for the excellent and the opening of the day and for the NeoCORE presentation. Thank you very much, sir. Now it's open for discussion.
I think you have given a lot of information, but at the end, probably the scene is not very encouraging. The way they go on and on for so many years. The end of everything, you lose the baby or developmentally delayed child. So, what percentage of babies anybody has done a study to see if you continue ventilation for so many days, not likely to have normal development? Of course, there will be an exception to the general rule. So, anything like
Yes, sir. We have a few babies who were 23, 24 weekers and ventilated for a long time. 50% of them survived to come back on follow-up. They surprise us by their resilience. Their development is not too bad. When I'm saying not too bad, because we only have 2-3 years follow-up currently, we are only saying they don't have cerebral palsy, they're not blind, they're not deaf. Some of them are having refraction with high powers, and a few of them had schooling and behavior issues, but there are others who have done well also. So what I tell myself a mantra and to my team is that if God has given them a normal brain, it is difficult for neonatologists to damage it. So it is quite resilient. But the number of therapies and long stay in ICUs will have definitely not only on the baby, even the families undergo a lot of behavior changes and they are not able to cope with managing these babies later. Even a URI makes them cry. Yesterday also I had a baby who was a doctor couple's baby, and they came from some 100 kilometers only because of a nasal discharge. And one of the doctor husband said, my wife is scared in dreams that today's URI may be tomorrow's ventilation. So it does affect their own development. Yes, it does.
Thank you, Naveen, for the wonderful lecture. I don't know whether we should be happy that we are all in the same boat or not, from what we heard from you. What's your talk on these BPD calculators which are there and where you can find out the risk of BPD in babies and address them with early steroid, probably in the 7th day or 2nd week if they are stuck on the ventilator? Do you look at them also?
Yeah, I feel that we have gone at least 1 decade beyond those calculators now, because at that time we were only trying to see whether to steroid them or not steroid them. But I feel that one of the Western person will have to write the last slide, then it will get acknowledged that BPD is BPD steroid, BPD PH, BPD CMB, BPD MBD. So one steroid cannot work for all. And a calculator, if it was for purpose of steroiding, I don't think it is going to be. But definitely, you may say, I want to do a genetic panel. And those who found pulmonary hypertension at 1 month, they say that they see high pulmonary pressures at 7th day. But I think it's largely only associations and it can't be called as prediction.
So thank you very much. For shortage of time, we will have a day-long discussion.
Sure,
so
sir.
next we have to go for the oration. Thank you very much, sir.
Thank you so much, sir.
Thank you, sir, for the insightful and stimulating sessions. I now request Dr. Professor Muthu Sumanan sir to hand over a small memento to Dr. Naveen Jain. We know what we were doing, it won't be called research. Once an old chap called Albert Einstein said that. Moving on to the most prestigious and awaited session of the day, Dr. R. Shanmugan Sundaram oration. I now invite Professor Dr. B. Lakshmi ma'am to reflect on the honoris contribution of Professor Dr. R. Shanmugan Sundaram